Hello, everyone, and dear all. A very warm welcome to the first webinar of the International Dohat Society in collaboration with the Technical University of Munich. We very much appreciate that you have joined us from across the globe from different time zones. I will quickly review some of the technicalities of Zoom webinars, which I'm sure you are familiar with now. At the bottom of the screen, there is a chat box where you can introduce yourselves and post any general comments you would like to share. For any questions to the speakers and for the panel discussion, please add it to the Q&A at the bottom of your Zoom app, and we will be able to use those for the panel discussion. All questions will be taken after the talks are over during the live panel session. I would like to add that the session is being recorded, so if you do not want your name mentioned during the Q&A, you can post anonymously. We have a very exciting line of speakers ahead, so I will not take more of your time. I am Dr. Chandini Jacob from the University of Southampton. I would like to call on my co-moderator for the evening, Dr. Michael Penkler from the Technical University of Munich now. Over to you, Michael.
So thank you very much. My name is Michael Penkler. I'm a postdoctoral researcher at the Munich Center for Technology and Society at the Technical University of Munich. And I'm going to introduce now the two hosts for today's webinar, Professor Mark Henson and Professor Ruth Miller. Professor Henson is one of the UK's leading researchers on developmental pathways to disease. He's the director of the Institute for Developmental Sciences and the British Heart Foundation Professor of Cardiovascular Science at the University of Southampton. And he's one of the founders of the International Society for Developmental Origins of Health and Disease and was president of the International Dohat Society until 2019. Besides his foundational work in Dohat, he's also known especially for work on public engagement and policy. And the second host is Professor Ruth Miller, who is co-director of the Munich Center for Technology and Society and professor for science and technology policy at the Technical University of Munich. She's a social science researcher who works on academic knowledge cultures and transformation, on emergent knowledge cultures in the life sciences, and on issues of gender diversity and social justice. And I'm now going to hand over for them for a short introduction before we get to the speakers.
So thank you very much indeed, Michi and Chandi, for introducing us, and welcome to you all on behalf of the Society for the Developmental Origins of Health and Disease, or DOHAD. The society was founded in 2003, and in a sense, its mission is encapsulated in this slide. The idea that the increasing threat to health and to low resilience to challenges develops across the life course. And it actually starts at the time of conception, hence the idea that development is so important in increasing that trajectory. You can see that the rising trajectory of risk goes across the life course, rising to higher levels and lower for some of us, but for all of us going into the red, the danger zone at some point in the life course. So the red zone occurs at different rates and at different ages. Needless to say, the problems build up across the life course and they add one to the other. So if we look at the bottom left, we can see that suboptimal pregnancy outcomes and indeed poor infant care lead to risks developing and the trajectory increasing. That feeds into low education of children, to poorer employment prospects, to poorer adolescent and adult health in turn, which then goes on to lead to greater risk of non-communicable diseases and to poor health in adults and aging. The tragedy, of course, is compounded by the fact that the risk is particularly of NCDs, is passed from one generation to the next. You see the arrow moving back leftwards across the graph there. Part of the reason that these risks increase at different rates in different populations and different individuals is shown by the blue box, because there are underlying inequalities in health and in social conditions. And these are linked to ethnic inequalities and gender inequalities. All these things are compounded by the COVID pandemic. And as you can see from the box on the right, both the direct and the indirect of COVID expose and amplify existing inequalities. loss of income, food insecurity, reduced education and social support, confinement, stress, domestic violence, and widening inequalities of every kind. And as I think an epidemiologist from the United States remarked some time ago, our political masters are always urging us to work together because they say we're all in the same boat. And he said, I don't think that's true. We may all be in the same storm, but we're certainly not in the same boat. In order to address this problem, clearly we need to take an approach that's beyond just a biomedical approach. And that really requires collaboration across disciplines. So some years ago, members of the DOHAT Society realized that it was extremely important to collaborate with our colleagues around the world in social sciences and in the humanities more generally. And for me and Chandni and others in Southampton, it's been a delight to work with colleagues in the Technical University of Munich, particularly in the Science, Technology and Society Studies Department, which Professor Ruth Müller leads. And so with that introduction, I'll hand over to my colleague, Ruth Müller.
Thank you, Mark. Thank you for starting us off in a really great way by emphasizing the importance of interdisciplinarity in this very specific moment in time. So my name is Ruth Müller. I'm a social scientist working on questions of how social, ethical, political issues are embedded in biomedical research and how biomedical research can help also address social and political questions. So over the last years, Mark and Chandni and Michael and I and our two research groups have been in a dialogue about the question of how we can use the DOHAT model in a way that actually could increase social equality. So when we're looking at research that looks at the question of how development influences later life chances to health, there are always like at least two dangers. One danger could be that we think about this in a very deterministic way, like in a sense, if X happens during early development, then this person is kind of scarred for life and might and will have a poor health. So this is something where we want to propose a more dynamic model that looks at different social aspects throughout the life course that influence health and illness. And then on the other hand, there's also a danger that we've seen in some of the literature that can lead to an individualization of risk, right? We all know the types of publications where we have an individual broken down behavior of a mother, for example, that is held responsible for a certain health outcome in the children without thinking about the social context that makes it possible for some people to maybe live in a way that contributes more to the health, and other people have to carry different types of burdens that might also put them at greater risk for health crisis, for health illness, which makes them vulnerable to different health emergencies. And this is really something that we've been seeing now in the corona crisis. As Mark said, like the corona crisis kind of really acts as an amplifying glass that shows us how the different health trajectories that are available to different people in society based on socioeconomic markers, racial markers, gender, or other markers of difference put people at different types of risk for acquiring the coronavirus, but also in terms of the outcomes. And so this connection really made us think about how can we bring the two communities, the biomedical community who look at this question of developmental origins of health and disease, the biomedical community who looks at the coronavirus, and the social science community who's interested in thinking through these questions of social justice in this very specific moment. How can we bring the communities together in order to start a dialogue and address these health inequalities that have been so magnified through the COVID-19 crisis? And this is what we want to do today. And I think we have a quite spectacular lineup of people who contribute to this question from different ends of the spectrum. And I will hand over to Michael now, who will introduce our speakers.
Yes, thank you very much. I will introduce now our first speaker, Professor Martha Kenney, who is professor at the Department of Women and Gender Studies at San Francisco State University. Martha is a feminist science studies scholar whose research explores the poetics and politics of biological storytelling, and her current work focuses on narratives emerging from the field of environmental epigenetics, where she investigates how assumptions about gender, race, class, and sexuality influenced the design of epigenetic experiments. And Martha is going to speak about social justice and recovery from COVID-19. So here you go. Thank you very much, Martha.
Good morning. My name is Martha Kenney. I'm Associate Professor of Women and Gender Studies at San Francisco State University. My field is Feminist Science and Technology Studies. My research and teaching offers social justice analysis of scientific research, public health policy, and technological innovation. This talk is based on a comment article in the Lancet Diabetes and Endocrinology entitled Back to Normal, Building Community Resilience After COVID-19 that was co-authored by myself, Michael Penkler, Mark Hansen, and Ruth Mueller. The examples and data in this talk are taken mostly from the US context, since this is the national context with which I'm most familiar. I encourage you to consider how you would apply this analysis to examples within your own communities and national contexts. Okay. Although the COVID-19 pandemic is far from over, many countries are now awaiting the mass production of a SARS-CoV-2 vaccine in the hopes of returning to some semblance of normality. But what should the new normal be? The pandemic has exposed how the status quo produced uneven vulnerability to COVID-19, with the most disadvantaged groups bearing the greatest health, social, and economic burden. In San Francisco, where I'm speaking to you from today, Latinx people account for 42% of the confirmed COVID cases, while comprising only 15% of the population. The reasons for these inequalities are complex and include historical and ongoing racism, unequal access to housing, education, and employment, as well as increased vulnerability to homelessness and incarceration. However, it is clear that we cannot account for the course of the pandemic without considering the social and political forces that have produced this uneven vulnerability. Health is never not political. One key public health term that deserves particular scrutiny in the context of COVID-19 is the category of the underlying condition. By now, we know that those with certain conditions, such as type 2 diabetes and hypertension, have had higher hospitalization and death rates due to COVID-19. These underlying conditions are often framed as the result of lifestyle choices, such as diet, smoking, and exercise, which implies that COVID risk lies within the control of the individual. However, the lifestyle framework diverts attention from the deeper causes of susceptibility, particularly how socioeconomic inequalities shape health risks. In the US, for example, rates of diabetes are highest amongst Indigenous, Latinx, and Black people who are subject to economic and social discrimination. Social determinants of health not only affect rates of non-communicable diseases, but also disease outcomes. In the US, Black diabetes patients are 3 times more likely to undergo an amputation due to diabetes than non-Black patients. When we use the term underlying conditions, we can often lose sight of these larger patterns of health inequality and locate risk and responsibility at the level of the individual. While on the one hand, it is important for us to know which health conditions lead to increased morbidity and mortality in COVID-19, it appears that the category of underlying condition is doing additional social and cultural work in both public health communications and the media. In his edited volume, Against Health, How Health Became the New Morality, social scientist Jonathan Metzl argues that when we make appeals to the seemingly innocent and politically neutral concept of health, that there are a highly charged set of moral assumptions that fly under the radar. In particular, there is a strong moral obligation to comply with bodily norms that are labeled healthy. norms that are inextricable from gender, race, sexuality, size, and disability. These moral assumptions are particularly conspicuous when obesity is counted among the underlying conditions that increase morbidity and mortality for COVID-19. Obesity is not a disease state, but a range of values on the body mass index, or BMI, which is obtained from a simple calculation of a person's weight divided by their height squared. Imprecise and far from neutral, obesity is a stigmatizing category that is often used to stand in for ill health, even in the absence of any indicators of disease. For COVID-19, the reason that obesity increases risk of severe illness are poorly understood, but this has not stopped public health officials and politicians from identifying identifying obesity as an important target of public health intervention. Perhaps most famously, UK Prime Minister Boris Johnson, speaking about his own COVID hospitalization, said simply, "I was too fat," using his own story to launch a new anti-obesity campaign for the COVID era. Here, Johnson uses self-recrimination to responsibilize UK citizens to manage their own health risk while ignoring the structural causes of unequal exposure and mortality. Never mind that most people do not have the resources of a prime minister to prioritize weight loss. Underlying conditions are often used to explain and simultaneously explain away deaths from COVID-19. Consider this bar graph from the San Francisco COVID data website. What are we supposed to take away from this data? Presumably, this graph is intended to convey the fact that most deaths due to COVID involve comorbidities. However, presented without commentary, it can also serve to soothe the fears of those who do not have underlying health conditions and make the deaths of those who do appear inevitable. As Jonathan Metzl writes, quote, "Affirmation of one's own health depends on the constant recognition and indeed the creation of the spoiled health of others," unquote. In this analysis, the category of underlying conditions works to separate a healthy us from an already unhealthy them. At its worst, this ideology supports a eugenic logic whereby those who do not conform with the norms of health are deemed disposable in the economic calculus of acceptable risk. Those who die of COVID without any underlying conditions are depicted as both anomalous and blameless, with news articles invariably reporting their young age and the fact that they had no underlying health conditions. Although it may seem ludicrous to be against health in a pandemic, a certain kind of healthism is being used to implicitly blame people for their underlying conditions and treat their deaths as an outcome of the individual mismanagement of health rather than as a result of structural inequalities and our social, political, and economic response to COVID-19. Research in the fields of the developmental origins of health and disease, DOHAD, and environmental epigenetics have revealed how adverse social and material conditions during early life increase later risk of many of the NCDs that increase the severity of COVID-19. This association accords with insights from the social sciences, showing how social structures like racism or socioeconomic deprivation become embodied, shaping health throughout the life course and across generations. Therefore, social justice is fundamental to promoting health in society. Resilience to health emergencies requires systemic rather than individual change. Here, there are opportunities for researchers in DOHAD and social science to work together on research to support health equity in the post-pandemic recovery phase. In particular, there's a need for research to support evidence-based social and public health policies that channel resources to marginalized communities and promote community resilience. Community resilience refers to the ability for people to support one another through hardships, including experiences of illness, disease, disability, and aging. Supporting community resilience requires centering the needs and voices of the most vulnerable and the equitable distribution of resources. There have been many compelling proposals for strengthening community resilience in the COVID era. The Hawaii State Commission on the Status of Women, for example, has proposed a post-pandemic recovery plan that advocates adopting universal basic income and single-payer healthcare, improving maternal and neonatal healthcare, addressing gender-based violence, and supporting Indigenous, Black, and immigrant women. The commission argues, quote, rather than rush to rebuild the status quo of inequality, we should encourage a deep structural transition to an economy that better values the work we know is essential to sustaining us. We should also address the crises in healthcare, social, ecological, and economic policies laid bare by the epidemic. Drawing on the DOHAD literature, we argue that recovery plans should also pay attention to groups who are not showing high COVID morbidity and mortality rates now, but whose experiences and exposures substantially affect community health in the long term, especially mothers and children. Divesting in maternal and child health during the period of economic recession following the pandemic will sow the seeds of later health inequality and NCD risk, which will undermine community resilience to future health emergencies. The Hawaii State Commission on the Status of Women has recently released a second report entitled Pushing Through the Panic, the Impact of COVID-19 on Pregnant and Birthing Women and People in Hawaii. What the report shows is that alongside the risks from the virus itself, pregnant women have been negatively affected by COVID policies that have not adequately taken their experiences into account. Hospital policies, which have focused on limiting hospital SARS-CoV-2 transmission, have proven challenging for prenatal care delivery and postnatal care. Policies limiting the number of visitors and requiring a mask at all times can be restrictive and bring fear and isolation to labor and delivery. The Commission recommends diversifying birth site options and creating more options for giving birth outside the hospitals. By providing alternative birth sites in the state of by providing alternative birth sites, the state of Hawaii could give more autonomy to women and demedicalize labor and birth. This idea is not new, but something that reproductive justice activists have advocated for a long time. The reproductive justice movement is a social movement led by women of color. Rather than arguing narrowly for the right to contraception and abortion, the reproductive justice movement supports, quote, the human right to maintain personal bodily autonomy, children, not have children, and parent the children we have in safe and sustainable communities, unquote. For reproductive justice advocates, issues such as police violence and toxic chemicals in the environment are reproductive issues, since these issues affect the ability to parent in safe and sustainable communities. Looking at COVID from a reproductive justice perspective requires us to address the persistent inequalities that create uneven vulnerability to severe COVID, as well as economic precarity and lack of parenting support caused by months of lockdown measures, as well as the possibility of additional post-COVID austerity measures. The challenge for DOHAD researchers who are interested in addressing the impacts of the pandemic on childhood development is to align research with the needs of parents and communities, and to avoid the individualizing and stigmatizing rhetoric that blames people for their own vulnerability. I'd like to end this talk with 4 recommendations for DOHAD researchers who seek to address the impact of COVID-19 on pregnancy, early childhood development, and parenting. These suggestions are drawn from my own work and from my colleagues in science and technology studies who are invested in scientific research that actively support social justice. While DOHAD research has the potential to highlight how access to safe and healthy environments benefit human development, these recommendations highlight strategies for strengthening the social justice framework and impact of this research. So number 1, continue to partner with STS scholars, social scientists, scholars, public health, designs that account for both biological and social complexity. Number 2, identify concerns and research questions that are relevant to the communities being studied. Number 3, avoid focusing on lifestyle and individual behaviors, such as the behaviors of pregnant women and mothers, and instead investigate the structural causes of inequality and the social determinants of health. Number 4, while there are many studies that show the negative health effects of early childhood adversity, there are few on the best practices to support people who have experienced adversity. Study which practices support community resilience. While many researchers are understandably reticent to do explicitly political research, a social justice lens shows us that public health is always political, and the policies that promote social justice, for example, universal basic income, are public health policies. Even in research that aims to be neutral, use of medical terms such as obesity and underlying condition do political work. It is therefore worth considering how the terms, questions, methods, and recommendations of the study strengthen or weaken social justice claims. Although the rallying cry that we are all in this together might encourage members of society to help reduce the spread of the virus, it also hides the fact that some groups are affected much more than others. We argue for community-led and state-supported initiatives for building resilience that focus on the most vulnerable among us and allow individuals, families, and communities to support each other in times of crisis and beyond. Ethical normal must encompass substantial systemic change that focuses on social, reproductive, and health justice and redefines the socioeconomic conditions we consider acceptable. Thank you.
Thank you very much, Martha, for your presentation. I'm introducing now the second speaker, who is Professor Tessa Roseboom. Tessa is Professor of Early Development and Health at the University of Amsterdam. Her work focuses on the impact of the early life environment on growth, development, and health throughout life. She's especially well known for her studies of the Dutch famine birth cohort, which provided the first direct evidence in humans that maternal nutrition during gestation affected offspring's and potentially grand offspring's health. She will speak about social justice and the rights of children as foundations to build back better. So thank you very much, Tessa, for being here.
Thank you. I hope you can see my screen.
Yes. So if you start presenting, then we'll see it even larger, I think.
Excellent. I have a slight problem with the menu bar being exactly where I want to click.
Oh, I see.
Let me have a look. I hope this works. So thank you very much for the introduction, and I'm very happy to share or be part of this webinar. My background is in biology, as you'll see from the first slide, and I would really like to argue that we should use the shit of this crisis as a fertilizer for the soil base to build a sustainable society for future generations. There are many examples, I think, from the past where crises have led to some positive effects, and I just wanted to share two examples with you, and you'll see in the course of my presentation why that is. The Second World War really made us realize that human rights are essential and a foundation for freedom, justice, and peace in the world. So the Declaration of Human Rights was really one of the positive effects that resulted from 2 world wars. And my studies have been in the long-term consequences of prenatal exposure to the Dutch famine, which occurred at the end of the Second World War in the Netherlands, where I live. And it has shown how fundamentally important the early life environment is for later health and well-being and for the ability of human beings to reach their developmental potential. So children have rights, they have children's rights, and they are made explicit in the Declaration of Children's Rights, stating that each and every child has the right to development and to survival, and that state parties have to ensure that children have the possibility to grow and develop. And although parents have the primary responsibility to help their child grow and develop, state parties have a responsibility in making sure that parents can give their children a good start in life. And just like any living creatures, both plants, animals and humans are very much shaped by the environment in which they grow and develop. And I think Muhammad Yunus, the Nobel Prize winner, described that really elegantly when he referred to poor people as bonsai people. The way we make bonsai trees is by restricting the soil base. And if human beings do not get the proper soil base to allow them to develop to their full potential, they really have no possibility to develop to that full potential, and they will bear the consequences of a poor soil base for the rest of their life, and most probably transmit that to the next generation as well. And the lessons that we have learned when we studied men and women who were exposed to a previous crisis, the Dutch famine, we found that people whose soil base was poor because their mothers did not have access to nutrition during pregnancy, we found that lack of building blocks when the heart, the liver, the lungs, and the kidneys of these individuals were formed led to increased risks of disease in later life. So both men and women who were exposed to the Dutch famine prenatally had increased rates of cardiovascular disease, they had increased rates of breast cancer, the metabolic syndrome, and it led to them developing those diseases at a younger age, but also it increased their risk of premature mortality. So it increased mortality of these diseases and significantly reduced their lifespan. Also, we found that people whose mothers did not have access to food during pregnancy have smaller brains. So when we looked at MRI scans of their brains, we saw that the lack of proper building blocks to build the brain led to structural changes in brain morphology that were related to function. So men and women who had been conceived during the famine and whose mothers lacked sufficient amounts of nutrients during the process of brain formation, they had smaller brains in adult life, they had poorer cognitive function, their brains aged more quickly, they had reduced perfusion, and this was also associated with poorer cognitive function, with increased problems with memory, with increased rates of addiction problems, with more antisocial personality disorders, and it also translated in reduced participation on the labor market. So this really suggests that growing up in a poor soil base and having reduced numbers or quality of building blocks to build the organs that will last a lifetime leaves lasting consequences for the risk of disease, for the ability to learn, for your ability to participate on the labor market, and it increases your risk of both physical and mental health problems as well as behavioral problems, really limiting people's ability to develop to their full potential. Obviously, the Dutch famine was very different from the current crisis that we're in, but a previous pandemic, that of the 1918 flu, had very similar, strikingly similar effects actually on those who were in utero at the time of the pandemic. So these studies show that men and women who were in their mother's womb when the 1918 flu pandemic struck ended up having increased risks of cardiovascular disease in later life, and that they had poorer cognitive performance. They had a reduced number of years of education, and a lower percentage of that cohort graduated from schools. Again, suggesting that a suboptimal environment in prenatal life increases the risk of cardiovascular disease and increases the risk of not being able to develop to your full potential also cognitively. So this really reiterates the statement of the president of the World Bank that a good start in life is really of fundamental importance for later equality in society. And he stated some years ago that 25% of all children being stunted through no fault of their own, but having inequality and poverty baked into their brains, is really the issue of our time. And I think now so more than ever, children are not getting the opportunity to develop to their full potential, lacking a strong infrastructure, their brains to build a strong society for now and the future. So based on the Dutch famine, we could think of it in this way, that the ability to develop to your full potential is really hampered if the soil base that was provided to you during critical periods of development was poor. And in the case of the Dutch famine, hunger or undernutrition during critical periods of development has lasting effects on your susceptibility to disease, on health, on the ability to learn, on your chances on the labor market, increases the inequalities in society, and it also affects behavior as well as the risk of addiction. And this really links very strongly to the Sustainable Development Goals. If we would be able to optimize the soil base for future generations, we wouldn't only make progress in terms of reducing undernutrition, but if we focused our efforts to reduce hunger in early life, we would also make progress on the SDGs 3, 4, 8, and 10 in terms of improving health, improving education, improving economic growth and work, and reducing inequalities. And I think at the same time, we would also have positive effects on several other sustainable development goals as well. So I think this is critically important, and not only is nutrition an important building block for building a more equal and just world, there are other factors as well. And I'd really like to focus on gender equality for a moment, because the first 9 months of our lives, the early environment that we grow and develop in is really provided by our mothers, since we're developing in our mother's womb. And as long as women have poorer access to various elements in society, I think not only women, but also their children are being exposed to unequal access to an opportunity to develop to their full potential. So women are more often exposed to violence, and we know that violence, especially domestic violence, often begins in pregnancy, and when it has already started before pregnancy, it intensifies. And we know that prenatal exposure to violence leaves lasting scars for the unborn child. The same holds for stress, the same holds for poverty, for lack of food and lack of education. And for each of these factors, there are clear gender inequalities that vary across the world, but in no place in the world women have equal access to these factors compared to men. And we know that this affects the health and well-being of their children as well. When we look at the COVID crisis, all these gender inequalities have increased. We have seen reports from various parts of the globe that violence against women and girls has increased dramatically, up to 5-fold increases in domestic violence. And this isn't only a problem for the women themselves, as well as for their children who fail to be able to reach their full potential. It also has a transgenerational aspect to it, because children who've been the victims of domestic violence are at increased risk of becoming perpetrators in the future as well. So this is really a vicious cycle that we need to stop as soon as possible. We've also seen that stress levels have gone up more so in women than in men. And we know that prenatal exposure to stress leaves lasting marks on the children. Poverty levels have increased, affecting women more than men. And food insecurity has gone up incredibly, also reducing the opportunities of the next generation to develop to their full potential. And one could wonder, well, what are the costs of this? Well, I just wanted to refer to this paper from Nature, where societal costs in different domains, in the health domain, in the criminal domain, in social welfare benefits, have been studied in New Zealand, and they showed that costs in all these different domains are highly correlated, and that around 20% of the population actually incurs 80% of the costs in terms of health, crime, and social welfare costs. And when the investigators studied what the 20% of the population had in common that actually incurred the majority of the societal costs, it was a poor start in life. And this really suggests that children who had a poor start in life do not get a fair chance on a healthy life, and that by investing in a good start in life and protecting the youngest generation, we might be able to gain a lot of benefit for current and future generations. And these findings have been replicated in Denmark and really show that there will be lots of benefits in different domains in society if we manage to protect the youngest generation. So in many ways, the voices of unborn children are unheard because we can't hear their voices, and they're often unseen, which means that they go unprotected. And I think we really need to make sure that we protect the unborn, because they will carry the longest and the largest burden from this current crisis. And one of the very positive messages I think we get from research in the area of developmental origins of health and disease in terms of disasters is this example from the Queensland flood study that showed that women who were pregnant during the floods, who were able to keep in contact with their midwife, fared better themselves. They reported lower levels of stress, but also their children fared better postnatally, with better developmental outcomes than children whose mothers experienced the same disaster, but were unable to continue to be in contact with their midwife. So I think social support is really an antidote to the stress that crises are inducing, and that we could use to protect the youngest generation. So I'd really like to argue that we currently need to invest in early human development to lay the foundations for a more just and sustainable future for all. I'd like to thank you all very much for your attention. Thank you.
Thanks very much, Tessa. I would like to remind the participants to post any questions in the Q&A box for Professor Rosenblum. Our next speaker is Professor Sarah Richardson. Sarah Richardson is Professor of the History of Science and Studies of Women, Gender, and Sexuality at Harvard University. She's a historian and studies the sciences of sex, gender, sexuality, and reproduction, and she directs the Harvard Gender Science Lab, a collaborative interdisciplinary research lab dedicated to research on sex and gender. She has also authored several key publications and books on the subject. Welcome, Sarah.
Hello, glad to be here. And thanks to all the speakers and the organizers for a wonderful program. My own research, this talk brings together two strands of my research that I previously thought were quite different. In the Gender Sci Lab, we focus on sex difference claims in the biomedical literature. And during COVID, the Harvard Gender Sci Lab has become an essential platform and resource for tracking sex disparities in COVID-19 outcomes. And in the first part of this talk, I'll share a little bit of our thinking and process and findings on sex differences in COVID-19 outcomes for fatalities and caseload. And then I'll try to bring that together with my other area of research. I have a forthcoming book on the history of ideas about maternal fetal effects, particularly the long reach of the intrauterine period. And that book, which will be out next year, raises a set of questions that might be relevant and intersect with how we think about sex disparities. I'm really glad Tessa Rosenblum just went and outlined some of the broad-ranging gender implications of the COVID-19 pandemic, because there is, I want to flag that although I'm speaking about gender, my focus will be on sex differences, and there is a burgeoning body of literature on the implications for women, in particular, of the many social changes that have been wrought by our moment. So let me begin. These are some headlines that exemplify how biological sex has been foregrounded as a primary explanatory factor of COVID-19 sex disparities. So to underline, sort of provide some context, in the early surge of the pandemic, it looked like men in aggregate were dying in far greater numbers than women. So in some localities as high as 2 to 1. And the first sort of head swivel was to biological factors. And some of these headlines suggest people looking into androgens and giving injections of estrogen, sex chromosomes, and so on. This is a screenshot from our COVID-19 tracker. This is a US state tracker where we are looking at mortality rates for women and men. And one thing this tracker will show you as soon as you look at it is that there's quite significant variation in the sex disparity across localities in the United States, and others have shown this across nations. And so it has become a platform, was cited in the New York Times yesterday, for discussing the importance of context and variation in interpreting claims about disparities in COVID. This is another image from our tracker. It shows longitudinally over time how the sex disparity has changed. And this isn't really an up-to-date screenshot, but to give you an example, in New York State, which had some of the largest surge in the US, in April, by the end of April, men were dying at a rate of 2 to 1 compared to women. But since April, it's been about a ratio of about 1.1. So there's been significant change over time and the gap is closing. Now, we well know that coronavirus cases and outcomes vary significantly by racial and ethnic group. And this is a finding widely understood to draw attention to the legacies of structural racism and white supremacy and the way that they contribute to health disparities. So racial segregation in the US in housing, zip codes, and occupational roles correlates with outcomes for COVID-19. And for example, as was flagged earlier by Martha Kenney, Black and Latinx Americans are overrepresented in these outcomes. They're also overrepresented in healthcare support and personal care service occupations, as well as many other high exposure professions. So we see the work that we're doing on sex disparities as adding to this picture of elevating the role of the social in mediating outcomes for COVID-19. Here's a quick image from a forthcoming paper from our group that is the very first to look intersectionally at sex and race ethnicity. So just as the sex disparity varies across localities and over time, it also varies across racial and ethnic groups in the United States. So this image shows that although in each group, men have fared a little bit worse than women, the magnitude of the disparity differs by groups, but also the mortality rates of men are not universally higher than the mortality rates of women. So you see in both these states, Georgia and Michigan, the only ones reporting data allowing us to do this analysis, Black women have poorer outcomes than white men in each group. So to assert that in aggregate, women have better outcomes than men just isn't accurate. Our probes into the question of sex disparity also insists on the importance of contextualizing any disparity within pre-existing disparities, that is prior to COVID-19. So I'm here showing work by Nancy Krieger at Harvard School of Public Health, but we're replicating this form of analysis across multiple US states and with a far greater period of time. But what this shows is in dotted lines, the average mortality for women and men in Massachusetts from January to mid-April, this is when the surge happened there, for the 5 years before 2020. And then what these lines show, of course, is that the dotted lines show that men had higher mortality rates than women prior to the pandemic. And then the solid lines show the average mortality for the mortality for men and women between January and mid-April 2020, when the height of the COVID surge happened in Massachusetts. Now you can see that the increase in mortality is identical with respect to the base, what one might call a baseline. So this is another way in which context matters for interpreting patterns of disparity. We are exploring in the lab how incomplete data reporting is also contributing to some of the disparities that are being observed in the US, and this has also been seen in Europe. Incomplete data on nursing home and home deaths is perhaps biasing estimates, especially in regions that have a high burden of elderly population. So in most places, women make up a higher proportion of the live-at-home elderly. And in the US, they make up about 70% of the US nursing home and assisted living population. And in the US, about 40% of coronavirus deaths are linked to these locations. And it's widely acknowledged that incomplete data on nursing homes and home deaths may be biasing estimates. We find in our tracker that mortality rates for men and women are more similar. In fact, women die at higher rates in Connecticut, for example, and Massachusetts, in these states where reporting of nursing home deaths is known to be more complete. Now, if we want to understand this, we need to look to how we argue there's a body of historical evidence, and the Spanish flu has already been referred to a couple of times in previous presentations, that gives us tools for thinking about how social variables can drive sex difference outcomes between men and women. When we look back at the NICE literature that's been done on sex differences in the flu pandemic of 1918, a pandemic that's been widely compared to the current one, it's clear that although men died from the flu in larger numbers, this sex disparity was driven primarily by specific groups of men that were disproportionately affected by the flu because of their occupational status. In particular, men in the military and manual laborers died at a much higher rate than the general population. And in retrospective analyses, middle class and upper class men died at identical rates to women. Additionally, men came into the pandemic, many in those same groups, with a higher rate of comorbidities, namely tuberculosis, compared to women, which made them more likely to die after contracting the flu virus. A more recent example can come from a couple of from other coronaviruses. So if we look at the SARS epidemic in 2003, this is a good example of how being very context specific about how to interpret the data really matters for looking at these disparities. So SARS in SARS, men also died at a higher rate than women, but in analyzing these findings, it was shown that sex differences in fatality rates varied significantly across ages. So the excess for men was primarily between the ages of 35 and 64, where men were 10% more likely to die than women. This is looking very, very similar to what we're finding now for COVID-19. However, the lower fatality rate among women was driven by a particularly high infection rate among healthcare workers, who are overwhelmingly women, predominantly female, but also young and otherwise healthy. So they were, in other words, more likely to survive the infection than their contemporaries who were men. So the high rates of infection among healthcare workers created the illusion that in younger groups, women were more likely to survive SARS than men. When in subsequent analyses, when adjusting for age, occupation, and pre-existing conditions, it was shown that women and men actually had similar fatality rates for SARS across all age groups. I know we need to wrap up, so I'll skip quickly over the example of MERS. And there are many gender-related factors that have been posited to influence COVID-19 gender-sex disparities. Polls and observational studies have shown that men in the US are less likely to wear masks, more likely to downplay the severity of the harm potentially caused to them by COVID-19, and behaviors such as hand washing, proactively seeking medical help, and observing social distancing measures men have shown less conformity to these. But I would really draw attention much less to individual behaviors than the structural aspects of the exposure of men to COVID-19. So it's very likely that men in aggregate are both being exposed at higher rates and in higher dosages in occupations that do not allow social distancing. On the other hand, as noted previously, women staff the majority of healthcare support positions in the US, and individuals working in healthcare support are more likely to get infected, but also more likely to get tested and to survive. And we note that the unequal distribution of comorbidities among genders likely influences COVID-19 disparities as well. So here's a quick snapshot of some of those disparities in the US context. Now, of course, comorbidities should be understood as producing biological preconditions that themselves reflect the interaction of social structural inequalities in access to healthcare and access to lifestyle choices conducive to health. And these factors are unevenly distributed among men and among women across social groups and should be accounted for when investigating disparities. Now, I want to bring it all together and offer a few wrap-ups here. I'm really glad in the last talk by Tessa Roseboom that we landed at this idea that the COVID-19 pandemic could be conceptualized as an exposure in itself, and that would allow the study of this exposure as a developmental incident. And this is now a common format for DOHAD-like studies. And this idea that we can study these incredibly complex events at the level of the body and biology, perhaps through markers such as epigenetic markers, that we can measure them and then we can track them, is a move that coheres cryptic findings into very bold biosocial theories, locating causality and agency often in the intrauterine period, collapsing scales from the molecular to the macrosomic levels of biological and social analysis, and temporalities and generations and history into these highly specific quantitative claims about brain size or levels of DNA methylation. And these produce compelling narratives charged with the urgency of preventing fetal harm, and with the promise that somehow a forthcoming applied science can redress this. And I think we see in this that the field, the science of maternal fetal effects has become one of the fields of speculation through which we understand and process the risk and uncertainty of our present world. And that's where I find some insights coming from my book on maternal fetal effects being very helpful for thinking about our moment with COVID. We're reasoning about risk under conditions of uncertainty and large gaps in data. And we're dealing with very complex social factors. The COVID-19 pandemic is not just a viral agent. The inequities we're seeing are not just caused by the virus. I would rather say, as my colleague Evelyn Hammond says, COVID does not create inequalities, it reveals them. And I think what we find through our COVID-19 project in the GenderSci Lab is a few lessons to extend on Martha Kenny's lessons for DOHAD researchers. Variation. Resist gender stereotypes and sex essentialism. As we talk about developmental origins and exposures, the insights that I have shared about men's exposures and patterns as well as women's will be important to include in an inclusive research design. Context matters. Mere exposure doesn't tell you enough. You need to understand the context in which that exposure happened in all sorts of ways. And again, the limitations of the data. We need humility about just what we know and how very much we don't know. Thank you very much.
Thank you very much, Sarah. Our next speaker is Professor Shane Norris. Shane Norris is professor within the Department of Pediatrics at the University of Witwatersrand, Johannesburg, South Africa. He is also president of the Africa chapter of the International DOHAD Society, and his research expertise is in life course nutrition, longitudinal birth cohort studies, and non-communicable disease epidemiology. His interests include maternal and child health, child nutrition, and intergenerational transmission, and the developmental origins of obesity and metabolic disease in low and middle income countries. Welcome, Shane, over to you.
Many thanks, and thank you for the invitation to present this evening. Just getting the slideshow up. Good. So for me, I'm taking one step back from the amazing presentations we've heard so far with a lot of very specific detail to kind of bring in a little bit of a global health focus and kind of picture how things are playing out on the global platform. And then in addition to drill down a little bit into the specificity by using South Africa as a case study, and then ending off with some learning that the COVID-19 pandemic has highlighted, particularly in the South African context. For the next couple of slides, I draw heavily on a fantastic resource. I highly recommend to certainly pay the website a visit, and it's Our World in Data at the University of Oxford. They've got amazing resource in terms of being able to visualize various components in these amazing data-driven figures. So the first one I'd like to kind of just put into context is the vast numbers of COVID-19 cases. So we're way over 60 million now, and you can see the incredible exponential curve of the pandemic from January through to now. In addition to that, these two figures highlight how governments have responded, and it's quite remarkable. So on the first figure on the left, we see government's response using an index that is based on several indicators and a 0 to 100 scale, with 100 being the strictest response to the pandemic. So you can see back in January 21 of this year that it's mainly China that starts to bring in certain responses in line with the COVID-19 emergence. But the picture on the right shows a remarkable difference just within a matter of months. So if you see from that diagram, sorry, I just want to try and move this Zoom panel. So if you see from that diagram, just by April the 7th, the remarkable difference globally, with many countries implementing very strict responses to COVID. And the important thing to note is how many low middle income countries are very quick to respond. And particularly you can see that in Africa and Southeast Asia. In terms of confirmed cases and testing, which these two figures show, the one on the left indicates, this is now current date, of how many daily cases are picked up in terms of COVID-19 per million. And this is a 7-day average. And you can see that the darker shades on the left indicating close to about 250 to 500 cases within a 7-day average per million. Heavily burdened in the Northern Hemisphere, but South America also heavily still affected with high numbers of daily detected cases, with some of these numbers coming down in parts of Africa. However, a key thing to note here is a limitation with these type of statistics and visualization of data is often hampered by the ability of these countries to test. And the figure on the right shows you the kind of daily COVID tests per 1,000 people. And there's a clear, stark difference between low middle income countries and high income countries in the ability to have a significant number of daily tests and reaching across the population of that country. So both cases and mortality statistics are probably underestimated in many low middle income countries. In terms of COVID-19 deaths, this figure shows the bi-weekly confirmed deaths over the past 2 weeks. And so this is recent data as of the 4th of December, so of the past 2 weeks, one can get the indication of confirmed deaths. And again, the kind of picture shows stark differences in deaths across the globe, but still many low middle income countries are facing significant mortality and obviously concurrent hospitalizations linked to COVID-19. In this figure over here, another indicator often cited and utilized is the case fertility rate. And the case fertility rate is the ratio between confirmed deaths and confirmed cases. There are limitations to this, particularly limitations over time, because we are responding to the pandemic activity. So we're constantly changing, we're detecting better ways to treat, manage, prevent. And so this shows, so it's useful to then view the case fatality rate over time. And in these figures over here, which spans March to current date, with a selection of countries and regions, you can clearly see that in the earliest stages of the pandemic, almost everywhere globally and in many high income and low middle income countries, the case fatality rate was substantially higher than it is today. And so the positive is that we've been able to adapt both in methods of prevention as well as management and treatment to reduce the case fatality rate to around the 4 to 6% level. Another useful indicator to get a sense of mortality and countries' response to COVID is to kind of relate the current mortality of 2020 to that of previous years. And in this diagram over here, excess mortality is highlighted. So this is cumulative deaths from all causes compared to previous years of all ages. This data, unfortunately, is mainly restricted to higher income countries, and a selection of those countries are shown. And as you can see, that for an overwhelming majority of these countries, with the 0% being the same cumulative deaths this year as opposed to the past period of 2015 to 2019, you can see many of these countries are way higher than that, with reaching plateaus around 25% and leveling off around between 10 to 15%. So that just gives one a sense of the pandemic and how it's played out in different regions in terms of government's response, the ability to detect or test, identify, and then the reflection in terms of mortality and the health burden within the global context. Now, with that lens on, now paying specific attention to South Africa as a case study, and to kind of drill down that when one looks at the global statistics, what's hidden is the inequality and social justice elements that don't play out within those kind of statistics. And one then has to really go into the more detail and zoom into countries' specifics to really be able to see that. So turning to South Africa responded incredibly quick. It initiated a very strict lockdown very early in the pandemic in South Africa. The minute infections were detected, government rapidly responded. In many ways, it's been certainly hailed as a good response. It's probably averted many hospitalizations and deaths in the early period, and allowed South Africa to begin preparing for the increase in COVID-related cases, particularly in terms of hospital preparedness. We had 5 levels, which spanned very strict at level 5, down to minimal restrictions at level 1. And this has spanned over an April to October to get from 5 to 1. We have about 815,000 cases with a recovery of about 91%. Very early on in the pandemic, we found interesting interactions with HIV, maternal and child health outcomes, and non-communicable diseases, both in terms of individuals that were on chronic medication and how that was severely interrupted because of the various lockdown procedures. And so those individuals receiving HIV, chronic treatment, hypertensive treatments and such, often didn't receive those necessary treatments as they should have regularly during this period. So there were severe disruptions on various levels. In addition, we found within the pediatric space that maternal and child visits to the baby wellness clinics, vaccinations, and other monitoring that we have in place were severely underutilized during this period. Unfortunately, coupled with these events, a corruption scandal broke, which was shown to highlight the kind of abuse of government funds in the procurement of PPE. And that was a devastating blow to government, and it severely impacted the kind of trust in the response of government, and that had an effect. In addition, it's been projected that 23 million South Africans will be pushed into poverty. So particularly in crowded townships, poor urban environments, staying at home, living in those conditions just does not allow for appropriate practicing of social distancing. Access to internet facilities to continue learning or schooling is difficult. We have a very large informal economy, which is severely hampered when there's the inability to move, to operate, and to sell goods. So the period from April to October, just a couple of months, has had a devastating effect on multiple South African communities. This year, the UN General Secretary gave the 18th Nelson Mandela Annual Lecture, and 3 key quotes from his lecture really resonate in terms of the South African case study as a highlight of the effect. The economic fallout has been substantial, and particularly in South Africa, it's affected women. What really has hit home, which was highlighted by his presentation, was that so much of one's chances in life are rooted if you male or female, or black or white, or your family background, and that these multiple inequalities in a very unequal society in South Africa really do intersect and reinforce each other. And as we've heard from Tessa and others, have incredibly strong effects intergenerationally. But the real worry, and it's certainly been highlighted by government and many various agencies in South Africa, is that given the fact that lives and expectations are largely determined by the circumstances at birth, that if we really are aiming to try and achieve human development goals and SDGs in South Africa, we really need to pay attention to these inequalities and severely narrow the gap. Government is incredibly sensitive to that and has initiated several programs, policy changes, but it's highly limited by funds. And for the first time in over 2 decades, South Africa is now having to take a loan from the World Bank to keep itself afloat by having to tackle the COVID pandemic and those related costs. So financially, despite the good intent, is a severe limitation in terms of what government can do. But the good news is that in times of crises, and if there's the ability to spark and to foster and to promote ground level initiatives, they can be incredibly effective. And what we've seen in South Africa is between the private sector, NGOs in partnership with government and communities really stepping up to tackle the kind of effects, the social effects of the pandemic and its related consequences. We've seen gender-based violence now being highlighted in South Africa as another key pandemic. And there's multiple community initiatives now to combat GBV, which has started. Between governments and NGOs trying to maintain social grants and nets and promote food security has been phenomenal to see in the most vulnerable rural and urban communities really play out. The WASH project, which is really trying to ensure clean toilets, access to clean water in informal settlements, have also sprung to life in a way that WASH wasn't getting traction prior to the COVID pandemic. And we've seen an amazing expansion of our community health worker program, with community health workers delivering testing in communities and messaging and referrals back to the primary health care. So these initiatives need to be nurtured, as they can be really useful and important solutions to the consequences of crises. So lastly, just to conclude, without a doubt, the COVID-19 has had a significant global impact, and probably in many ways in different sense, both high income and low middle income countries. Public trust is absolutely critical in these times, and for government to ensure adequate information, adherence to prevention protocols, there needs to be that trust. Anything, be it from corruption to leaders that kind of downplay science, those elements have real effects and need to be highlighted as things that we need to take away from this and learn in the event of future crises. The poor cannot remain invisible. It's absolutely essential, as we've heard from all the speakers, that understanding these social determinants of health more and bringing that into the DOHAT field, the DOHAT literature is absolutely critical. And lastly, we need to promote ground level efforts and communities to both tackle and contribute solutions. Many thanks.
Thank you so much, Shane. For commentary on talks until now, I would like to call upon Professor Clarissa Prazeres da Costa. She is co-director of the Center for Global Health at the Technical University of Munich, and she's professor of infection and immunology and infectious disease consultant at the medical faculty. She also leads a research group interested in the immune responses against helminth infections, also in a transgenerational manner with a focus on low and middle income settings. She also has interest in women's health in sub-Saharan Africa and novel technologies in global health. Welcome, Clarissa.
Clarissa, I don't know if you experience any technical difficulties, but we can neither hear nor see you. Okay, now we can see you.
Here she is. Okay, thank you very much for the organizers for this kind of introduction, and many thanks for organizing this important webinar, which I've enjoyed very much so far. So just quick commentary, which I was invited to by Ruth, and thanks for that. So being an infectious disease specialist and immunologist, of course, I would like to add the perspective of our immune system as the interface between self and the environment. And so my main research focuses on how parasites, and especially helminths, as communicable organisms found mainly in low middle income countries these days have actually developed many tricks to evade their host's immune system on the one hand side, but also how our immune system has evolved evolutionary under the constant exposure to what some people nowadays call old friends and some call them old foes. So why is that so? So like COVID-19, many parasites are zoonotic and have complicated life cycles in nature. So close human environment interaction perpetuate their existence. And but humans as the host have learned to live with them, and the immunological strategies humans have developed during evolution to live with these parasites actually have spillover effects to prevent other non-communicable diseases, such as, for example, allergies or also autoimmune diseases. So I would like to add the aspect of the hygiene hypothesis and to bring the environment and eventually planetary health aspects into our debate. And we have been learning to understand that the root of allergies, for example, might lie in dysregulation of immune responses that have originally evolved to cope with challenges presented by old friends. And now their removal due to increased hygiene means the removal of the regulatory processes induced by their presence. And this renders us humans and possibly even society less healthy and less resilient, coming back to our initial question of resilience now. And also in that case, possibly more vulnerable and prone to develop certain non-communicable diseases. So, and in relation finally to DOHAT, our research has recently also uncovered that such chronic infections by environmentally transmitted parasites renders the next generation, so the children, the offspring, less susceptible to develop allergies. And we are only now starting to learn some more of these underlying mechanisms, such as epigenetics. So I would just like to bring forward that the right to hygiene, which we would consider a universal one, obviously, and if enacted globally, should not deviate us too much from our original, what I would call a protective environment in terms of opportunity. And this could eventually improve social resilience in the long term, even across generations. So I'm very happy to have had this possibility to make this very brief comment on how to bring into also perspectives, I would say, of our environment and how our environment, a protective environment, can render us more resilient also in social terms. So thank you very much.
Thank you very much, Clarissa. Thanks to all speakers and commentators for such informative and thought-provoking talks. I would now like to invite all speakers and panelists to please turn on your video for the panel discussion. Some questions may be addressed to a particular speaker, but please feel free to use the raise hand function to jump in. Michael, if you would like to start with the first question, please.
Yes, of course. So it's a question that has been addressed to Martha by Katja, and it focuses on, Martha, you have recommended to focus research on which practices support community resilience. And the listener was wondering how you've measured community resilience in the past and which methods have proven to be useful in doing so.
Hi, yeah, thanks for the question. I think it's a really good one. I've personally not measured community resilience in my own work, but Ruth Mueller and I have been studying counties in the US Pacific Northwest that have been drawing on research on early life adversity to address the effects of adverse childhood experiences, or ACEs. And Walla Walla, Washington, which is one of the epicenters of this grassroots movement, has been using community-wide resilience as a measure. I stuck the URL in the Q&A for anyone who's interested. This is a study where they've attempted to create a metric to measure the effects of all of the initiatives that they've done to address adverse childhood experiences, like across many different sectors and human services. I think metrics are really important and really political. As I said when I was talking about the BMI, body mass index, even though it's just weight divided by height squared, it carries a particular authority. And so I think creating metrics that reflect social justice values can be an important tool in forwarding the social justice impacts of this kind of research. So I think that measuring community resilience is something that people are only just starting to do, and that we're really going to need expertise across the life sciences, the biomedical sciences, public health, and the social sciences to develop meaningful metrics for community-wide resilience. So I really hope that some of the folks in the audience are interested in this and would like to take up this challenge because I think it could be a really promising approach to doing this kind of work.
Thank you, Martha. Mark, you have raised your hand. You want to weigh in?
Thank you. One of the problems with measuring resilience is that strictly you can only measure it afterwards. Something's broken and you think, oh, well, that wasn't very resilient. Of course, it's the slope of the line that I had in my opening graph, because an additional challenge in a less resilient person or a less resilient population will mean that the risk will go up a little bit more steeply. And I think we've got a real problem here in trying to tease out the biological from the social factors. And I wanted actually to flip this one, if I may, over to Sarah, because really just to ask you, is there, we read every day that there are links to testosterone or estrogen or genetics, etc. Do you think when you put it all together, there's actually any evidence for a gender difference in susceptibility to COVID? Or is it all exposure and risk? In other words, on that resilience line, men and women are the same, but actually they're not because their exposures are different.
Oh, goodness. I think it's a way too early to tell, but I think the findings that we have so far definitely suggest that at best, biological sex variables explain a small amount of the variation and the disparities. Because that variation is so significant across social groups, across location, and across time, and because of the templates provided by previous epidemics, the going hypothesis that we're working with is that gender and other social and demographic variables, including comorbidities, which, as I said, should not be misunderstood as themselves biological variables, but are deeply socially situated, pre-existing inequities as well, are the strongest contributors to that. And we have looked at some of the biological literature. It's very speculative, and the differences, if any, are small and do not reflect the patterns that we're seeing. So I think the reason we emphasize this is that if you focus on the wrong cause, you could be failing to see the vulnerabilities that really do need to be addressed. So it does present to us this really good example of, as you say, taking care to not falsely see a disparity as reflecting biology when really what it might reflect are these social disparities.
Yes, sadly, I think many governments around the world don't want to recognize the real causes. It's just too damned inconvenient.
May I maybe briefly follow up on Sarah? I think she said a very important word there, patterns, because it does not reflect actually the patterns that we in the end see with regard to gender and COVID, but what it does reflect is the patterns in which we're thinking. Right. So the idea that if we see a difference between people who live their lives as men and women, we think, oh, there must be some underlying biological difference. And I think we're really reaching this point where we would need to come to a turning point and kind of put our patterns a little bit upside down and develop the habit to ask these more complex social questions. And similarly, in DOHAD, there might be sometimes this limitation that you very well pointed out, Sarah, to kind of think then just about mothers as isolated individuals, right? And here we again need to start to put this pattern upside down and think in a way more complex manner about how certain things might be coming together and what might be the really kind of key issues to look at. So I think this questions of patterns of thought is really important when we think about these issues.
We also have a question for Tessa on DOHAD from Chris, and that DOHAD has primarily demonstrated long-term negative impacts of prenatal stresses. And what message does DOHAD really provide for interventions? Is it about adult lifestyle or not? And after this, I would also like to ask the panel to build on this, particularly Martha and Sarah, from your talks. How do we resist telling deterministic stories that leave no room for resilience and change throughout the life course, and telling stories that simplify the causes and effects in ways that in the end obscure rather than reveal social complexity? So Tessa, if you would like to start off.
Well, thanks. That's quite a complex question in itself, I think. What we've learned from the studies is that obviously the early environment is really important in shaping potential later on, but it doesn't mean that all is lost after a poor start in life. There are certainly many things that one could do to stimulate resilience, and I think there are many examples of what people might do. My personal approach to this has been to really much more stress the importance of prevention and reducing, for instance, gender inequality, rather than trying to repair things that have gone wrong earlier. So in a policy sense, I do think that it is very important to get the message across that having a poor start in life before birth, already having your odds of the likelihood of developing to your full potential being reduced is something that needs much more attention in policy measures, rather than continuing to invest mainly in repairing damage that has been done earlier.
Yeah, although I think that prevention is very important, I think it's also important to recognize that that people are living in adverse social and material conditions now, and that there are a lot of people who have already had adverse childhood experiences, have already undergone, stress, abuse, neglect, these kinds of social experiences that that we know have biological effects. So I think it's important for us to be very careful in the rhetoric of not pathologizing people who have had many of these very common experiences, and also to focus health and other public policies around being able to support people, including people who have had these experiences. So yes. The folks that Ruth and I are studying in the Pacific Northwest, they're looking at introducing trauma-informed practices to schools and other institutions that work with young people, and that those practices are good not just for the kids who have had these experiences, but they're good for everyone because they provide support and teach emotional regulation and offer positive responses to behaviors rather than just punitive measures. And so I think this is one of these places, I think, where people in the biomedical sciences and in the social sciences can come together and figure out ways of telling these stories so it doesn't seem like people have been scarred for life and that the people who haven't had those experiences, they're going to have these healthy, prosperous lives, and the people who've had these experiences aren't going to. And so even as we're learning these things, I think, as Eve Tuck points out, that we shouldn't be focusing on the damage. We should be asking these questions around community support, community resilience, around healing. And that's, I think, also building studies around these questions could be more empowering than studying the damage over and over and over again.
I fully agree. And I think also because of the transgenerational aspects, it's very important to focus on the potential of support programs. And for instance, in our country, we're focusing on I'm looking for the word, sorry, parenting courses, especially supporting young parents in their roles as young parents. And that really is a positive, very positive movement trying to highlight that everyone in society benefits if we make parents stronger individuals in learning how to regulate emotions and recognizing that earlier experiences shape ourselves, and that we transmit part of that to future generations as well.
I want to jump in on the question of how to reduce determinisms. And I do think that emphasizing resilience where resilience is possible and there is evidence for it is important. But I wanted to just add a few distinctions to that here. Really, it isn't determinism that is the worry to me so much here, because absolutely everyone would agree that we're talking about risks and that these are statistical risks that play out across populations and actually small variations in risk. And that really the concern, to follow on what Martha said, is about introducing essentialisms so that these people are risks or these people are high risk, and creating ideas about categories of people who are problem people. And relatedly, the concern is about reductionism, if we're going to add some isms, and that is that we think there is a variable, there is a factor that can be measured at the level of the body that actually reflects this complex social phenomenon. So I'm far more concerned about two other isms, reductionism and essentialism, than I am about determinism, because I think that one is really is on all of those in this space to contextualize risks. And the idea here should be to produce knowledge that empowers. It may, in the end, show that there are negative impacts that can't be overcome, negative risks. There may not be a story of resilience in some cases, but you have to give people knowledge that they can then take back in the context of their life in relation to other risks. And so often the knowledge is presented in such a way that it sounds like a very, very large risk that is a lesioning and that should be prevented at all costs. And we don't live in a world where no level of risk is acceptable. So a very healthy discussion about risk and what kinds of risk we can invite, and always taking on board the autonomy of people to weigh risks for themselves.
Okay, I have a couple of comments and questions from the audience, which build very nicely on what we've been discussing so far. So Lucilla, for example, says that we as a DOAD, building on what Shana said, we as a DOAD community need to focus on the widening inequalities arising from COVID and provide the evidence to persuade governments of a renewed focus on critical periods of development. And Michelle has posted a question, a comment which builds also nicely on that. She says she's struck by the tension between us not wishing to individualize DOAD interventions by focusing on the mother-child diet, but also needing to be able to mobilize funding for DOAD, nutrition and maternal child health in what is now a highly competitive funding and aid landscape. And this leads her to two questions. First, how can we explicitly use a social determinants, social justice framework in DOAD research in ways that will have traction? How best to do that? And secondly, how might we rethink the language we use to avoid the gendered language that Sarah was discussing? I would address this question first to Shane, I think, and then open it up to the plenary.
Thanks, Michael. So just tackling parts of the questions posed. So certainly, I think the DOAD community, I think the first critical thing is to ensure that we include the vulnerable populations into our study designs. We've already had several discussions a bit tonight and previously at different DOAD forums where we are missing men in the equation. And similarly, it may be difficult to include the most vulnerable populations in our studies. They may be more mobile. They may have other limitations or barriers to prevent them from engaging with the scientists. And so our population selection, I think, is a critical first step in how we can be thinking in terms of DOAD research and these issues. Part of also with that is we then capture a variety of exposures, and getting better granularity in exposure will also help us tease out the associations and build the longitudinal evidence of effects on different both proximal and distal outcomes. So yeah, I'll just end on that point. Thank you.
Ruth, please.
Yeah, maybe if I can follow up on that. I think one really, I want to reiterate a point that Martha mentioned earlier. So one of the hesitations I sometimes experience when interacting with DOAD researchers, but also other biomedical scientists, is this idea that the way in which a lot of the discourse is currently phrased is kind of neutral and not political. And this is something Martha was talking about, right? So for example, if we talk about maternal nutritional habits and lifestyle determine then this is sometimes seen as something that is neutral and just a statement of fact. But in fact, it is not. It is a specific narrative that focuses in on the individual and that foregrounds individual assumptions about individual agency, assumptions about certain choice patterns. We could tell the same story also quite differently by talking about the food infrastructure that is provided and the landscape of having to work multiple jobs or so on. So we could, go one step at different other variables. But that is seen then as political. And I think one very important thing is for the DOAD community and for other communities in the biomedical sciences who work with individuals and give causal narratives about health and disease is to acknowledge that any narrative they give is a political narrative. And that might maybe encourage researchers more to actively engage with social justice frameworks if they understand that their narrative is political in any way. And then the second point, and Michelle Pentecost raised that very importantly, is language. I think we have in the medical and biological sciences, we have way too little training to develop sensitivity around language and about the social and political character of language choices. And I think here again, we need to have
way more discussions as the one that we're having right here of what do I say if I use certain terminologies. And with Mark and others, we've of course had a lot of discussions, for example, about ideas like epigenetic programming. What does that mean if I use the terminology programming, right? That's a very tough, that seems like things are set in stone now. So encouraging this type of reflection about what the words that we use do, and that they are never neutral but always political. I think that is very important, and that's a challenge to be met, particularly in an increasingly complex global political landscape that is full of challenges.
Yeah, and just to build off of that, I think that one thing that we can do collectively is to build these narrative choreographies that avoid the pathologizing or individualizing or essentializing aspects of these complex social and biological phenomena. But I don't think we need to reinvent the wheel. Like, there are lots of people who have already done this kind of careful work with language in the political realm. And that's one reason I referenced the reproductive justice movement, because they have done a really great job of reframing reproductive rights. Like, reproductive rights is about a woman's bodily autonomy and access to contraception and abortion. But reproductive justice puts that within the larger social and political context. It's about being the right to be a parent, to not be a parent, and to parent the children that we have in safe and sustainable communities. So taking something that could be individualized or understood in a very narrow framework, and to be able to think about it in a wider social justice context. So using the kind of language and these kinds of these narrative moves that activists and scholars have already developed, I think could be really effective within a DOHAT or other biomedical contexts. Obviously, that kind of work of translation and adaptation would need to be done. But as Ruth said, since all narratives are political, it makes sense to actually work within the narrative tissue of the biomedical sciences to develop narratives that are politically effective in ways that we desire.
And to continue the point about not reinventing the wheel, there has been good work by cognitive scientists on the particular frame of maternal fetal harm and the problems with that frame. So that is a cognitive frame that raises such intense and charged feelings. It comes with such intensity that it becomes difficult to think critically once a claim of maternal fetal harm has been launched. And to be able to put on board the total social imaginary around a situation, a risk, is something that all of us should be invested in. And so a very simple suggestion is to avoid the alternative collapsing framing of maternal fetal harm. And secondly, to always contextualize risk claims. Decontextualize risk claims create free-floating claims of harms that are challenging to integrate, again, into this wider social imaginary. So it's one thing to profess and affirm that, yes, of course, social factors play a role in this. But unless you attend to the social imaginary that you're creating with these kinds of claims, it may be that this language is eclipsing the ability to think holistically, creatively, openly about all of the variables in play. So we can talk about risk, but it needs to be contextualized. We can talk about harm without it being this intensely charged maternal fetal harm frame.
Okay, thank you very much for the really excellent discussion and engagement. Thank you for all the excellent questions that have been raised by the audience. Unfortunately, we were by far not able to address them all, but we have to slowly to come to the wrap up. I want also to thank personally all the panelists for the really exciting presentations and the really engaged discussion. And I would now hand off to Mark and Ruth for the farewell and for the final wrap up. Thank you very much.
You want to start?
So I just want to add my thanks to yours, Michi, to everyone for sticking with us. I'm sure it's an antisocial time for some of our nearly 100 people still on the call. I think this has been a really stimulating discussion. It's just the beginning, I think, of some discussions that I'm sure will be continuing. It really demonstrates not only the importance of thinking about maternal, neonatal and child health in the context of DOHAD, but how social factors really brought to the fore and gender factors and ethnic factors, and because they're all linked, have been exaggerated and worsened by COVID. So I think collaboration is essential, not only between the DOHADers and the social scientists and the people in the humanities, but between experts in social justice, our legal colleagues. After all, justice should be the same across the world. That was the idea of the United Nations and the World Health Organization all those years after the Second World War. And in many ways, we sort of feel as if those of us who were born just after the war, feel as if we're kind of in rather the same situation. And I think that the other point about collaboration, of course, is that hopefully we can learn. As many people have said, we're none of us safe until we're all safe. So the lessons that Shane showed us, for example, in South Africa, could be applied directly to the things that Sarah was talking about in Black women being more at risk than white men in some states. I think this is a very stimulating and incredibly important area for research. So let's pick up the cudgels and take this on, because I think it really is just so crucial. Thank you all for joining us and for listening. Over to you, Ruth.
Thanks, Mark. I couldn't agree more. And I think, so I feel like we've just started talking, right? It feels like we've just kind of prepared the ground for really engaging and developing approaches, how we could move forward. I think I want to return to this question that we kind of chose as a theme for this event today, this question of back to normal ? And I think I am so bold to say that our collective response is that a back to normal is not the way forward in so many ways. And I think we've been talking about a number of these ways, right? We have the COVID-19 crisis hasn't created the social inequalities that we see contributing overwhelmingly to these vulnerabilities that put people at risk based on gender. And here we say it might be men who might be put more at risk, or race, ethnicity, occupation, income, all these different factors, right? So going back to normal would be something that would be really deadly and for many, many people. But also going back to normal in a way is maybe not what we want to be doing in science, right? We've been discussing right now how we want to shift certain paradigms. We want to increase more attention to socioeconomic conditions, for example, in early life. But at the same time, we want to do that differently than we've been doing before. Sarah was talking about patterns earlier, and I think there is a real need that we change, our patterns of thought. Like, how are we thinking about an issue? How are we thinking, as Martha and Sarah pointed out, of the idea of pre-existing conditions, right? Do we think about them decontextualized as something that is just a feature of a body, or do we think about them in a much broader social sense, where we look at where things come from and how they build across life courses? And I think there is a real need that we change this, and that and these conversations across scientific fields, but also across different forms of practitioners, like people who are working, for example, in social work or in different social justice organizations, are really necessary to shift that frame, to help us develop new patterns so that we think differently on a regular basis, and will at some point develop different study designs, and it's just a very natural habit because our frame of mind has shifted. And I think for this, we really need ongoing conversations together. And in this sense, we also see this as the first event in a series of events where we want to have these conversations and develop new forms of exchange, new languages together. And I'm really glad that so many people joined us for this today, and that people joined us from basically all over the world. That is really, really quite wonderful. And yeah, all I can say is, in a sense, stay tuned. And I hope we will continue this conversation soon. Michi, Chandni, will you see us off?
I just want to wrap up saying thanks all for joining us. I'm sure it's very early in the morning or very late at night somewhere. So thank you and have a lovely week.